they have any questions, they can reach out to us, or, you're the chief notes taker for tonight, so they can reach out to you if needed. So we want to thank all of you guys for joining us tonight. We all have a really exciting opportunity to affect children in their growth and development and make sure that they can live their best life. And so I know we all have a common goal, and it's really important that we all reach that together. So I want to introduce myself. I'm Dr. Rosello. This is Dr. Yantorni. So we are general dentists here in Orlando, and we've been focusing our practices on sleep disordered breathing, both in children and adults, and how we can grow and develop their jaws to allow for improved breathing, sleeping, and ultimately living. So without further ado, we'll get started. So I think we all certainly know the importance of sleep, and if we're not getting good sleep, the detriment that can cause. And in children, that's only magnified. Kids who don't sleep well certainly suffer a variety of health issues. And our goal is to show you that the development and the anatomy, the positioning of the jaw bones affects this, especially for children. The connection to whole body health and the importance of sleeping and breathing is certainly something that we're well aware of. And we want to make sure that we do everything to help develop the facial structures and the bones to be able to allow for the best breathing for each of these kiddos.
So to start, we're going to begin with just a little bit of an anatomy review. Don't want to talk down to anybody here. I know you all know what all these bones are, but hopefully it'll make a little bit of sense about why we're here and why you're talking to dentists about something like this. So obviously this is the maxilla. The maxilla is a really big bone that sits in the upper midface. It's the same bone that the bone that holds all of the upper teeth in place. It is also the roof of the mouth, but it also forms the floor of the nasal cavity as well as the lateral borders of the nose. The oropharynx, that tube which all air must pass through to get to the trachea and the lungs, whether nasal breathing or mouth breathing, air must pass through the oropharynx. The tongue there is the anterior border of the oropharynx. And the tongue, by means of the floor of the mouth, is connected to the lower jaw bone. I can't see my screen. If the lower jaw or tongue is too far back, the airway may be compromised. If the airway is compromised, sleep may and likely will suffer, both early and late in life. Good. Again, since the tongue is connected to the lower jaw, if the jaw is moved forward, the tongue will move with it. When the tongue moves forward with the lower jaw, the oropharynx volume increases and airflow improves. Okay. While many may think that it is strictly genetics that determines the facial form, there's a direct relationship between breathing and facial bone development. What we find is that how we breathe matters. Proper breathing is critical for full and proper facial development. And in contrast, improper breathing often leads to improper bone development. Furthermore, improper bone development can then worsen and magnify improper breathing. Here's a video explaining the basics of the relationship between breathing and jaw bone development.
The normal way to breathe is through your nose. As we grow and develop, certain things such as pollen, cow milk, and other variables can cause an allergic reaction, causing the lymphoid tissues known as tonsils and adenoids to become swollen. As the tonsils and adenoids become swollen, they develop into an obstruction for nasal breathing, and slowly mouth breathing begins to be the primary intake of air into the body. In order to breathe through the mouth, the lower jaw comes down, the tongue comes off the palate and settles on the lower teeth. Nasal breathing is the correct way for air to enter the body, and during nasal breathing, the tongue rests at the palate and the pressure of the cheeks is balanced by the tongue. During mouth breathing, the pressure from the cheeks is unopposed by the tongue. The oral system becomes unbalanced and results in the deformation of the upper jaw, creating a V-shaped arch as opposed to a correct U-shaped arch.
So that video explains how nasal breathing and how mouth breathing affect the development of the upper jaw bones, and how when we breathe properly through the nose, the upper jaw is able to develop completely and wide and without crowding. Let's take that a step further and see how it can affect the lower jaw bone as well. This arch that's on the screen, the gray one there, represents the upper arch, and the blue arch should be the lower arch, and it should fit right into the upper arch, kind of like the way a foot would slide into a shoe. That's not how all arches form. If the upper arch were to develop narrow, then when the lower arch tries to slide into it, it can't slide all the way forward. It gets stuck midway or not all the way forward. Okay. When this happens, the lower jaw sticks out the back. And that's exactly what we see in dentistry as well. This on the left is a normal bite, where all the lower teeth at the back are lined up and everything interdigitates properly. But when the upper arch is too narrow, the lower arch cannot slide as far forward, and we end up with an overbite. The lower jaw remains too far back. When we see that, we oftentimes get the appearance of the receding chin. And we also get other characteristics that form similarly, such as tired eyes, bad posture. A smaller airway can develop as well. So this video here will talk a little bit about the consequences of what can happen if that lower jaw is too far back. It didn't play.
The narrowing of the upper arch pushes the lower jaw back. This forces the TMJ condyle to shift distally while the TMJ disc shifts forward. Upon opening, the disc can shift onto the condyle to restore the TMJ's correct position, reduction of the disc, and then shift back to an incorrect forward position upon closing. This is what causes a reciprocal click. In addition, the muscles could be in a state of hypertonus or spasm, which can result in tension headache. An incorrect position of the lower jaw can result in parafunctional activity of the muscles, such as clenching and grinding. Over time, grinding can result in severely worn down teeth. As a result, the teeth become even shorter, the lower jaw shifts distally even further, and the vertical of the bite decreases. In time, joint degeneration occurs. The joint becomes deformed, and the ligaments of the joint become damaged. As a result, the TMJ disc can get trapped in front of the condyle. While the click may go away, limited mouth opening will occur. A distally shifted jaw and tongue positions result in even further restriction of the airway. In order to open up the airway, the neck moves forward and the head tilts backward. This stresses the spine and fatigues the neck muscles, which results in neck, back, and shoulder pain.
So I bet you never thought that how a person breathes when they're young and developing could set them up for a lifetime of negative consequences if that breathing is not proper. Again, this is what happens to the airway. This is what happens to the airway when the bones are underdeveloped. If the lower jaw can slide into the upper, oftentimes what we get, or usually what we will get, is a wide open airway at the back. But with the narrow upper jaw and the lower jaw that slides not as far forward, quite frequently we will see a narrow or squashed airway at the back. And that's what these photos here will represent. This picture on the left represents a person who has all their teeth, all 32 teeth, including the wisdom teeth, and we can see the airway at the back, how wide open it is. That makes for a patient who can breathe quite easily. Whereas this patient on the right is someone who had extractions due to small jaws and extreme crowding, extractions with orthodontics, which makes the mouth smaller, forces the tongue distally, and can create a much smaller airway. Again, improper breathing leads to deficient bone development, and the deficiencies in bone development make breathing more difficult. The cycle must be broken or serious long-term consequences can happen. A person who is not breathing well may suffer from a variety of health issues throughout life, from ADD to sleep apnea, increased blood pressure, cardiac disease, stroke incidence, and more. Additionally, improper facial bone development can lead to a number of undesirable social and cosmetic outcomes. Social and cosmetic outcomes such as severe crowding. Extreme crowding like this can result in years of orthodontics in the middle and high school years. No one wants to have braces on for many years during those times. A deep bite occurs when the upper teeth erupt unopposed. You see, teeth will erupt until they hit something, usually when they hit the opposing teeth. But when the lower jaw is positioned too far back, there are no opposing teeth for the upper teeth to contact, so they continue to over-erupt. This gives the appearance of an unattractive gummy smile with teeth very out of position. Not to mention an additional stress this can place on the TMJ and the muscles. When the lower jawbone is not able to develop properly, it cannot support the soft tissue profile of the face. We can clearly see here how the lower face and lack of chin are less than ideal cosmetically. This photo shows how a properly positioned lower jawbone affects the soft tissue profile of the person. There's no doubt that the picture on the right is a more desirable outcome. Somebody asked me when I first put this picture up, are those actually the same people? And yes, they are actually the same person. Same here. Both this photo and the one before are examples of how faces can change when the bones are in the right position. Both of these patients underwent reconstructive jaw surgery to cut, reposition, and splint the lower jawbone into the proper position. This accounts for a dramatical physical and emotional change, but comes at a significant cost, not just monetarily, but in time and discomfort during surgery, or recovery from surgery. Recovery time is typically no less than 2 to 3 months, with a significant portion of that time being wired shut.
All right. So this is a typical x-ray that most general dentists would take in their practice. And it's great because you can see all the teeth and we get a good view of what's going on, but there's a lot of information that might be missing in this view. So this is a 3D cone beam CT scan, which we take on all of our patients. This is something we've been doing for over a decade. Initially, it was for wisdom teeth extractions or implant planning, but what we've really determined is that there's so much more that we can see in this 3D x-ray. And one of those things that we can see is really the structures of the airway. So when we take a look at our 3D x-ray, we can really evaluate on whether or not we have this wide open airway in the back, or if there's some of these pinch points where a patient may be at risk for having sleep disordered breathing. And so it's really important when we identify this that we can talk to the patients and really evaluate what exactly, some of their problems might be because of this. Excellent. So the problem is an underdeveloped jaw. And this underdeveloped jaw leads to the tongue being pushed back into the airway. This poor tongue position obstructs the airway and can affect breathing and sleep. So what's the solution? The solution is to develop the jaw bones. Using maxillary expansion to widen the upper arch, we can reposition the lower arch forward, bring the tongue forward, up and out of the airway. Along with a shift to nasal breathing, which we can do with better nasal hygiene, myofunctional therapy, and some breathe training mouth guards. So this is one of the appliances that we would use. This appliance allows for many functions. One of the functions is to allow for a proper lip seal. When a patient puts this appliance in their mouth, it moves the lower jaw forward and encourages nasal breathing, but it also helps the lips seal around the appliance, making it difficult to breathe through the mouth and forcing the patient to be able to breathe through their nose. With proper nasal breathing, a patient gets much better oxygenation and has a lot of health benefits. This is another one of the appliances here. You can see this appliance positions the lower jaw forward in a trough, positioned ideally along with the upper jaw. There's also a tab right there in the palate where the tongue can rest against. This is a myofunctional appliance that helps train the tongue to live up in the roof of the mouth, all the way forward and up and out of the airway. So this myofunctional appliance, along with myofunctional exercises that we do with our patients, gives that training for the tongue to be positioned properly and help drive growth in children, because the tongue is an essential piece of our growth and development. Additionally, we have appliances like this that can be used to grow and develop the jaws both in children and adults. These appliances can drive that lateral growth of the upper jaw, allowing the lower jaw to then fit further forward within that maxilla. All right, so as we alluded, the tongue is the best appliance. This tongue is super strong. And with a tongue positioned properly, especially in children, it'll actually drive the growth of the maxilla all on its own. So myofunctional therapy is super important, and tongue positioning is one of the things that we really work hard with on all of our pediatric patients, because the tongue can be a great driver of growth. So relative to size, the tongue really is the strongest muscle in the body. And so with that force, we really want to get that positioned properly and let it do the work for us. And that's something that's one of the things that we include in all of our treatment for our pediatric patients. All right, so what can you guys do? Well, I think through our presentation tonight, we can all agree that optimal breathing happens when the facial bones form properly. So we need to be able to recognize when the bones are not forming properly and intervene so that we can get these children developing properly, growing properly, and breathing properly. All right, so some of the things we can look for. Dental crowding. Anytime that teeth don't line up properly, there's a likely sign that there's a lack of proper jaw development. So when you're looking in a patient's mouth, you can see clearly whether or not the teeth line up. A lot of times the teeth are mispositioned, or when we look together, we want to see, are all the upper teeth lining up properly with the lower teeth? If they're not, there's a likely jaw development discrepancy there. Another area you can look is underneath the tongue. As we mentioned before, the tongue drives growth. The tongue has to be free to move within the oral cavity and push up against the roof of the mouth. In this picture here, we have a thick lingual frenum that's holding that tongue from being able to move freely. So if you see a patient who has a tongue tie like this, it's important to have that addressed and get that patient to have that tongue released so that with myofunctional therapy, it can actually learn to live up in the roof of the mouth, all the way up and forward, driving that growth for the children. All right, so here's a few more of those bites that we saw earlier. On the upper left, we have the deep bite, where we can't really even see any of those lower teeth. When you have a child smile, biting their teeth together, you should see the majority of both the upper and the lower teeth. You shouldn't see tons of extra gummy tissue, but you should be able to see the upper and lower teeth. If the upper teeth are completely covering over the lower teeth, that's a sign that that lower jaw is sitting too far back. In the second picture, you can definitely see where we have that bucked tooth appearance, where the upper teeth are sitting out way farther than that lower jaw that's sitting way far back. And when we have a case like this, that tongue is being pushed back into the airway, and a lot of times we have that sleep disordered breathing. All right, so here we see excessive tooth grinding. So these teeth are worn down, and that's definitely something where bruxism and tooth grinding is often associated with sleep disordered breathing, especially in kids. So when we see this excessive wear, that's a sign that maybe we're also having some underdevelopment. Enlarged tonsils may be another sign that we're having some difficulty with breathing and possibly some jaw underdevelopment. Whenever we see this, we should definitely evaluate for those other signs and symptoms that we've been talking about, because we clearly may have an issue with the nasal breathing.
Yeah, when you see these large tonsils looking in the back of the throat there, once you see those, you should maybe take an extra second and then look at the dentition as well. Because what you will probably see is that patients who have these really large tonsils probably also have either a very narrow arch or also have moderate to significant dental crowding. And when we see that moderate to significant dental crowding, we know that the jaw bones aren't developing the way that they're supposed to. And if they're not developing the way that they're supposed to, there's a really good likelihood that it could be affecting breathing as well.
Children in primary dentition should have spaces in between all their teeth. And the teeth, when they smile, you should be able to see the upper and the lower teeth. We should have crowding, especially in the primary dentition, and even teeth that are sitting right one next to each other would be considered dental crowding, because primary teeth should have spaces in between them because there's much bigger teeth coming. All right, so this is a mouth breather here. Clearly, if the lips are chapped and resting open, if we're seeing those tired eyes, the dark circles under the eyes, sometimes the crooked nose or the chin that's pushed all the way back where you look like you can barely even see the chin, a long, narrow face, and even that forward head posture that we alluded to earlier, those are all signs that we might have a smaller airway, something that's causing a problem.
It's just science.
All right, so when a mouth breather takes in air, it passes to the lungs unfiltered. This may increase the tendency for asthmatic attacks in susceptible patients, as they breathe in more debris and allergens. The solution is to get the patients breathing through their nose. With nasal breathing, inhaled air is filtered in the nose and the nasal sinuses. it can then pass on into the lungs for absorption. So our goal would be to get patients, using appliances and getting maxillary expansion, which will also increase the nasal cavity volume, allowing patients to breathe better through their nose. And especially in patients who are susceptible to nasal inflammation or allergies, if we can get them breathing through their nose instead of through their mouth, this will increase the likelihood that they will have less asthmatic symptoms. Whereas asthma is just one of the conditions we tend to see in these patients with underdevelopment, there is a whole list of additional comorbidities that are typically seen in a patient with sleep disordered breathing and many times jaw underdevelopment. We see these patients in our practice every single day, but we would venture to guess that most of the patients that you guys see have at least one of these conditions, and likely they would also have significant jaw underdevelopment.
So we know you are typically seeing pediatric patients, but we thought we'd show you how a treatment protocol that we're describing here of developing the jaw bones and positioning the lower jaw and the tongue in the more proper position affects adults with sleep and breathing problems. So this is a study that was published in the Journal of Sleep Disorder and Therapy, and it basically follows one person through their struggles. Down on the bottom, there's the abstract, but we'll sort of sum it up for you like this, okay? This patient is a 27-year-old female, and they reported the dentist's office with TMD symptoms and was screened for obstructive sleep apnea. Screening shows significant risks, and a sleep test was recommended. A level 1 sleep study showed an AHI of 118 events per hour. They were referred to the ENT for a tonsillectomy, which reduced the AHI to 70 events per hour, and then it was controlled with CPAP. After going through this jaw development protocol, where the upper and lower jaw bones were developed, the lower jaw was positioned more anteriorly in the face, getting the tongue out of the oropharynx and opening and freeing up breathing. 10 months later, a follow-up sleep test was done, and it showed 1 event per hour, and this was with no CPAP or oral appliance in the mouth. This is another study which follows 19 patients, all of whom were 21 years or older. There's a matrix here with a number of different, a bunch of different data that goes from AHI before and after treatment, their RDI before and after treatment, as well as their ODI. And basically the results are as follows. Prior to treatment, the average AHI was 12.8 events per hour, and the ODI was 6.3%. Again, after treatment, follow-up home sleep tests were done at 9 months, and it indicated a mean AHI decrease significantly to 6.2 events per hour, which is a 51% decrease. The ODI was improved as well. And these aren't individual sort of results. We see these types of results all the time, and it's definitely changing people's lives, which is fantastic. Again, this is without any appliance, still in the mouth. So we feel if we can develop the bones and get everything in their proper position, then the patient can just live life in those proper positions without needing any sort of splint moving forward.
All right, well, we thought we'd show you just a few of the results that we've had within our practices. This is an 11-year-old boy who at the beginning of treatment was snoring horribly. Parents came in just, describing lots of different symptoms that we see each and every day with difficulty in school and snoring and restless sleep. And we were able to, in 11 months of appliance therapy, change the airway for this child from what we see on the left, which has lots of red, which indicates, volumetric deficiency, to what we see on the right side, which is almost all green with just a little bit of the yellow deficiency. So this is the volumetric calculations. And so we definitely increased dramatically the volume of the airway from about 8,500 millimeters squared to about 13,000 millimeters squared. So a significant increase for this patient. And what we all like to see, his initial AHI during sleep test was 4.1. and we reduced that to a 2 after 11 months. So we've reduced 51%. But I will tell you that what you're seeing in this child is remarkably different. You know, sleeping much better, no longer snoring, doing much better in school, you know, going from a BC student to a straight A student. So these are the kind of things that really make a difference in a child's life. And when they're young, all of the benefits that they get from good sleep and growth and development are just remarkable. Here's another patient. We're looking at, you know, 9 months of treatment, and we're looking at inside the nasal passages. Obviously, this is just a snapshot in time, but we're evaluating almost a, you know, doubling in the amount of nasal conscious space for this particular patient after 9 months of treatment. Again, we're looking at the airway, and we've had some gains here, not, you know, super remarkable necessarily in what we're seeing here, but just a couple of millimeters of space is like miles in this area. But what's most remarkable is what we see in his 9 months of treatment. He went from an AHI of 27 to an AHI of 6, a 77% reduction. This has totally changed this man's life. His wife no longer hears him snoring. He no longer is waking up tired every single day. He's sleeping many less hours, but feeling much more rested when he's waking up. So again, a wonderful, remarkable transition for this gentleman. So this is our contact information. We have an amazing website put together with tons of information about what it is that we're doing. breathingwellnessorlando.com. This is a place where patients can go, or even y'all can go if you want to find out more about what we're doing with our appliance therapy. breathingwellnessorlando@gmail.com is our website and email. So we would love to be able to chat with you about any questions you might have. We'd love for you to send your patients to, you know, get more information about what we're doing if you think it's something that we could help. We know that there's a lot of patients that you guys see that probably could utilize this therapy. So we'd love to take questions that you might have at this point.
So a lot of people look at orthodontics and they think of it as a cosmetic thing, but there's a major functional aspect to it. When the teeth are in their proper position, the muscles, they work better, they work with each other better, the joint is happier, and breathing is simplified and made easier because of how everything in the body is kind of connected there. So when we're looking at orthodontics, we're looking far beyond just the position of the teeth. We're looking at the position of the muscles and the balance of the position of the bones and the balance of the muscles to make sure that everything is working properly with each other. So when we think about orthodontics, we should think beyond just the position of the teeth and think about those other things as well.
All right, if anybody wants to unmute, we're happy to have a conversation at this point.
I'm just curious, as the psychologist, what is compliance like, especially in the kids with the appliance?
Yeah.
And then when you were describing using the appliance with the CPAP, I was like, oh, what is compliance like then?
So the appliance therapy isn't something that's worn 24 hours a day. 12 to 16 hours is our goal. So especially in kiddos, most of that time is going to be when they're sleeping. We also encourage use during reading or watching TV or being on an iPad. So most kids like that they can bargain for extra iPad time because they're going to be wearing their appliance. So we actually have fairly excellent compliance with the appliances themselves. And as far as wearing it with the CPAP, I mean, it depends on exactly what their mask is. But if they're already putting on a CPAP, putting this on in addition to that is really, the CPAP is way more difficult to wear than these appliances.
Some of the dual and combined therapies were done for that study's purpose as well. And they didn't want to take them off the CPAP immediately on patients who were in the severe category for concerns of what is that going to do to the patient. But what we're finding in study after study after study is that just positioning that jaw further forward immediately will take a patient from a severe AHI down to a very much reduced AHI even without developing the jawbone at all. So just using those mandibular advancements do a good job to at least reduce the AHI to a point where we probably don't have to use the CPAP at the same time anymore. But then over time, development of that upper jawbone allows us to get better airflow, less resistance, and allows for better breathing overall.
So what about coverage? I know that many of them have dental coverages, and then obviously we're talking about a diagnosis that allows you to have a medical coverage. So how does this work in terms of cost for a patient or a child,
So with children, most of them are in sort of that orthodontic age anyway. So I find that it's easy to sort of incorporate that a lot with orthodontics. And most of them will kind of fall in line with that time frame. So the dental we can use without a doubt, dental insurance. Medical.
Yeah, the medical insurance isn't something that we're having a lot of great success with children. We do have some cases that we're working with, but typically what we're going to find is that patients are going to be utilizing dental coverage for the orthodontics. And then this is something that, we do payment plans because you're going through treatment for a period of time. Depending on how old the child is, it will depend on how long the patient is in treatment. And then we break up the payments over the course of treatment. So most of the time we can get them into low monthly payments that, most families can afford. Again, most parents are planning on some sort of orthodontic plan at some point. And so this is going to alleviate the need for further, braces down the line, because we're going to grow and develop the jaw to a point where the teeth are going to be able to come in naturally, more aligned, and not need that additional treatment of orthodontics down the way. So most families find that this is a option that gives them both the orthodontic, but also additional health benefits.
So, just to follow up with that question, you said the difference between that may have benefit for the further orthodontic treatment plans that's there. The question arises, what's the difference that the projected savings? Like if someone's like, okay, I could avoid getting braces and going down that line, and versus doing this aspect, what are we looking at? And because a lot of times parents will ask us, well, what does that really mean at the end, tail end? For a lot of times the dads, you say, well, what is it going to cost me?
The big cost in that is really it's not a financial cost per se. The cost is when you go in and you get traditional orthodontics, we're lining up the teeth, and traditional orthodontics neglects position of the bone, neglects muscle activity, and they're not thinking about the airway. So the costs really don't come in while the kid is, or while the patient is a child. Oftentimes the cost isn't really till they're an adult and they've got sleep apnea because their jaw bones are too small and the tongue is in the airway. And then they all of a sudden start to develop high blood pressure and other sort of issues associated with that. Cost-wise, it's probably pretty similar to a full round of orthodontics, but we're doing so much more when we start early and we can develop the bones to their proper sizes and spaces. And health-wise, it is a major step above and beyond the traditional orthodontics.
Okay, and then I'm sorry to bombard you, just
Great.
things that come up in the past, What about those who do singing, instruments? Is it going to affect any of that? Obviously, when we're dealing with bone development and moving the typical sounds are going to be different. Have you guys noted anything?
Yeah. No, the growth is not happening quickly. It takes time, and there really isn't anything that they're not adapting to as this growth and development is occurring. So I haven't had any patients, even my patients who are in braces, which when you throw those metal brackets on, it significantly can change how they're doing with singing or instruments. But I haven't had any patients who weren't able to adapt to that very, very quickly.
These appliances that we're talking about are removable. So if there was some sort of a sport or instrument, you take them out for practice and events and things like that. And the movement is so slow that there wouldn't be a speech impediment that develops over time. I want to go real quick back to that insurance question real quick. You guys deal with medical insurance all the time, us not so much, but they really don't like giving us any sort of benefits as dentists, right? It would be really interesting to see what would happen if we got a referral from a medical doctor suggesting that we do some form of treatment or therapy, and then see how the medical insurance responds to that. Because most of our treatment right now has been on our own current dental patients. And even with those who have tested with an AHI of greater than 1 in a pediatric patient, which is considered sleep apnea in a child, most insurances say, well, if they don't have significant comorbidities, we're not going to cover any sort of therapy anyway.
Send them for a tonsillectomy. That's what we get.
Exactly. But if we were to get a referral from a sleep specialist in some form who wanted to do something else, I think that would put the medical insurance into a situation where they'd be much more likely to do something. Because again, we're dentists, and you guys, this is your area. Awesome.
Anybody else have any other questions for us? We're happy to answer. We just see that there's a need for us to grow and develop and prevent the problems, because that's what we're trying to do, is prevent the problems. The younger we can get these kids, the faster we can fix the underdevelopment and get the tongue positioned properly. Then we're just sending them on the road to being able to grow and develop the way that they're supposed to. And we're so thrilled to be able to get to these patients sooner rather than later. And we're preventing their, stunting of their growth and the breathing issues that they're having and the difficulty that they're having sleeping and the ADHD symptoms that they're exhibiting because they're just exhausted all the time. And when they get older, it's the sleep apnea and the heart disease. Those are all things that we're preventing. And the cost up front is, in the ballpark of what a typical kid who goes through, a round of braces at 8 or 9 and another round of braces at 12. And that's what we're preventing is, so the cost financially is similar to what many of these parents are paying already in orthodontic treatment. But you're getting so much more of a result. Yes, you're getting straight teeth that line up and bite properly, but you're getting them positioned out of the airway so that that tongue lives in the oral cavity and not in the oral pharynx.
What is the youngest age that you guys have treated?
2, 3 is the youngest.
That age, we see people or see those kids and their parents basically bring them in because they're restless sleepers, they're snoring, and they might be hearing grinding of the teeth. And most of the time, those kids are given one of those breathe trainers. It's like a rubbery football player's mouth guard, which just helps to position the jaw in a better spot, increases the volume inside the mouth, and helps to allow that tongue to get into a better spot, helps train for nasal breathing. That's about the majority of the most that we'd be able to do on somebody that young. But again, if the tongue can get into the roof of the mouth, somebody that young can make major developments in a very short amount of time, to the point where they may not need to have that guard or that guide in the mouth for too long before they start having correction. And again, the earlier that we get to somebody, the less extensive the problem that will be. Very likely the less costs that there will be associated with that, for sure.
And what's the longevity of the success? So meaning that I know with orthodontics in the past that people have the braces and shortly after you lose the effectiveness, you got to keep that guard. And you hear people mentioning over and over. And so in this scenario, what's the...
So yeah, this is one of my favorite things to talk about, where traditional orthodontics, I sort of say that there's a triangle of things that we have to talk about. We have to talk about the teeth, we have to talk about the bones, and we have to talk about the muscles. If your orthodontist isn't talking to you about all three, then they're kind of forgetting something. Orthodontists typically will put teeth into their proper positions, forgetting about the other. But in reality, the best retainer in the mouth are the soft tissues. And what we find is that the tongue is typically underdeveloped and not strong enough to continue to push forward and hold the teeth in their proper positions. So the muscles of the outer face, the cheeks and the lips tend to pull in, which creates for a smaller mouth, and that's where we get a lot of the dental relapse. If the tongue were strong enough, being trained well, then we can use it as the best retainer, and the longevity should be permanent.
So when you have a well-developed upper jawbone, that tongue fits up and into the roof of the mouth. But if you don't start with a properly developed jawbone and you have this very narrow vaulted palate, that tongue can't fit up into the palate. And so the tongue doesn't have the opportunity to be that natural retainer. So what we're doing is providing the triangle of benefit where we're looking at the soft tissue, the bone, the muscles, the teeth, everything is coming together in harmony. Whereas when you're just moving the teeth to make them all line up, you're not putting everything else in harmony. So that's why we have this relapse in ortho. Whereas our patients, if we have the natural retention with the cheeks and the tongue in balance, then we're not going to have all that relapse.
Now, what happens if it's a scenario that you have significant more nasopharyngeal swelling from like significant allergies or a deviated septum that's very significant? Would they be a good candidate for something like this if the obstruction up top is so significant that they're going to be mouth breathers?
Well, we talk to all of our patients about good nasal hygiene. Obviously, blowing the nose, using like a clear spray, which helps reduce the bacterial inflammation. Sometimes even some breathe right strips just to help things open up. But at some point, if the septum is that deviated and there's that much of a blockage, ENT comes into play at times. And so we do refer out to ENT if we see things that are, just not resolving. But if we can get the palate to open up and widen and develop, we're also opening up and widening that floor of the nose. So we're seeing a lot of those patients who have this inability to breathe through their nose. If we're giving them the good nasal hygiene and the nasal breathing instructions, we're doing the myofunctional therapy, and we're also getting that bony growth, we are seeing patients have significant increase in ability to breathe nasally, even when they do have a lot of these obstructions. And the more we can get them to breathe through their nose, the less inflammation they're going to have, because the more we can filter out the particles, the more we're going to keep reducing. So it's a cycle. If we can get them to breathe through their nose a little bit, it's going to make it easier to breathe through their nose.
I've been doing all that questions, guys. You guys have anything?
Fantastic.
Awesome.
Just keep sending them to him. He'll read all your questions.
They're not sending it to me. These were just questions.
So one of the first slides we went over today was just about the basic bone, the maxilla, and how we said that it holds all the teeth in place, but it is also the inferior and lateral borders of the nose. And so when we do a maxillary expansion and we're widening the teeth with our appliances and things like that, it has an effect on the nasal space as well. So those people who have extremely narrow nasal spaces, significantly deviated septums, we can increase the intranasal volume by doing those expanders. And that gets them on the right path towards better nasal breathing. Is in severely deviated septums, like Dr. Rosello said, may we still need some ENT help? It's possible, but we got to start somewhere.
So do you guys have any questions about what you would do if you wanted to refer a patient to us? I know we've been by the office and we met with Dr. Ajay pre-pandemic. We dropped off a lot of information and brochures and information. Are you guys all working out of the Winter Park office? No. So we're happy to get you more information to pass out to your patients. What would be the best way to get that to you all?
If you bring it over to the main office, typically if you have it more electronically available, it's probably the best.
Yeah, we can put something together.
Available. Yeah, if it's like a PDF format or some other format.
Absolutely.
And we're able to generate it so it's very accessible to all of our providers, as well as access to it in case they run short or can I find it, paper goes missing very quickly.
We will get that over to the main office this week.
Wonderful. Yeah, I want to thank you both. You guys were great. I think it was very enlightening. I would ask if we were able to record this, it'd be great to share it with the others that weren't able to attend. And then if we have any future questions that they generate or anyone else has, especially those who didn't attend, if you're open to us just kind of reaching out to you guys and kind of feeding it through.
Absolutely.
I think, I've had discussions with Dr. Ajay and we were talking about this is something that we just never really explored. And something, a lot of it is just because it's just one that I think, again, insurance carriers, up and coming, how much everyone's aware of and everything else. And so I think as time has gone on, it's just we have to kind of add more, as we were talking earlier, add more to what we can offer our patients when they come in and they don't fit any one category that currently we've been providing them.
Excellent. Well, we thank you guys all for your time this evening. I know our out of work time is precious. So thank you for joining us, and we will get that recording over to you guys as well so you can share it.
Yeah, wonderful. Thank you both.
Absolutely. Thank you. Have a great night.
Thank you.